Welcome, everyone. We will get started in just a moment, giving everyone a chance to join the Zoom. All right, so right off the bat, Christine has her hand raised. So Christine, do you have a question? I can unmute you. Okay, Christine. So if you have a question, feel free to drop that in the box. I see that your hand is raised. But we are going to go ahead and get started. My name is Stephanie Erdis. I am the Associate Director of MCASA, and I'm very glad to have you all here today for our second training for the virtual campus training series that MCASA hosts every year. Today's training is about the sexual assault forensic exam and what is helpful for campus staff in prevention and response to know. So we are delighted to have Grace Rupp, MCASA's SART and PREA policy specialist, and Dr. Jessica Volz, the clinical director of forensics at Shady Grove Medical Center in Rockville, presenting for us today. These two are experts, both in the knowledge and have a lot of experience in this. So I'm excited to hear what they have to share with us today. Before we get started, just a few housekeeping items. We do have ASL interpreters with us today, so they're both spotlighted. So you can see those folks on your screen. We'll be recording today's webinar, so that will also be available to you early next week. We encourage you to use the chat and the Q&A to introduce yourself or ask questions. And we also will have an evaluation at the end of today's program, so we encourage you to fill that out. That helps us with our grant funding and improve our programs. So with that, friends, I'm going to turn it over to Grace to get us started. Thank you again for being with us today.
Thank you, Steph. My name is Grace Rupp. I use she and her pronouns. I am MCASA's Sexual Assault Response Team and Prison Rape Elimination Act Policy Specialist. I'm so excited to be here with you today. I will be covering an overview of trauma, how our college survivors might be demonstrating some of these symptoms and behaviors, and then how to best support them. I'll pop it over to Dr. Volz quickly to introduce herself.
Thank you. Good morning, everyone. Thanks for joining us. My name is Dr. Jessica Volz. I am a nurse practitioner and the clinical director of the Forensic Medical Unit at Shady Grove Medical Center. And that is here in Montgomery County, Maryland. And I hope to give you some information today on the role of the forensic nurse examiner, what we do, and how that can be helpful to you in the Title IX context.
Right, so quickly thinking about what is trauma. Trauma is a normal emotional response to an extremely distressing event, such as sexual assault. There are other events that can lead to trauma, things like national disaster, large accidents, unexpected death, war, political violence. But traumatic events create emotions so intense that they overcome our normal coping mechanisms. Traumatic events place us outside of our window of tolerance, the space in which we are comfortable, we feel safe, we can regulate, we can think rationally, and can deal with the stress of everyday life. The stress trauma produces can be temporary or can leave survivors with long-term impacts. One of those long-term impacts could be a PTSD diagnosis. So, experiencing trauma. We're going to discuss the definition of trauma and the symptoms someone who has experienced trauma may demonstrate. It's important to note that I will be referencing the DSM definition of and criteria for a PTSD diagnosis. However, not all survivors of sexual assault will necessarily meet the criteria for a formal diagnosis of PTSD. That is normal and does not invalidate or suggest the trauma they experienced was not real or difficult or bad enough. The first criteria that the DSM provides for a PTSD diagnosis is simply that a person was exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence in various ways. It's important in this diagnosis that it includes direct exposure or witnessing trauma, meaning indirect exposure. For example, indirect exposure might include listening to the details of trauma. This happens a lot for people in our field and in our profession. Other indirect exposures can include learning of experiences that maybe somebody in your friend group or family had, and that would expose you to trauma as well. So the trauma symptoms and PTSD symptoms can show up in a variety of different ways, but you can re-experience trauma in the following ways. So you might have things like unwanted or upsetting memories. You might experience nightmares or flashbacks. A lot of folks also avoid trauma-related stimuli. So trauma-related reminders, they might experience negative thoughts or feelings associated with that event. They might also show a decrease in interest in activities. Additionally, the feeling of isolation. So that might express itself in even negative or flat affect. It's important to know, though, that these symptoms look different in every person and are experienced in a variety of ways and a variety of intensities. So when we think about our work with college survivors and college students, how might these symptoms show up? How might they show up for an advocate or a college administrator, a Title IX officer? So what do they really look like on a college campus? And then how can we help our students who might be experiencing these? So for students who are re-experiencing trauma, they might be having those flashbacks, nightmares, difficulty sleeping. And this may affect their feeling of safety on campus, in the dorm, in the dining halls, in classes. Because of that lack of sleep, they might have difficulty focusing. They might struggle to participate in the activities that they previously enjoyed. They might see big shifts in appetite, really having some serious executive functioning issues, which impacts their ability to perform academically. Student survivors who are experiencing that avoidance of trauma-related stimuli, this can come out again in a variety of ways. So they might be avoiding the perpetrator. They might be avoiding spaces that the perpetrator frequents, or avoiding third-party witnesses to the event. I've seen student survivors avoid certain places on campus. So for students who have been sexually assaulted in their dorm room, they're avoiding their dorm room, or they're avoiding certain classes. They may be dropping classes or switching out of classes that the perpetrator is also enrolled in. They might be taking longer routes to avoid said person. So this shows up in really different ways with varying intensities for our students. One thing that I think we need to address more seriously is the sensation of feeling isolated. So I found that survivors not only feel isolation from the event itself, but also the social consequences from the trauma. So for example, I would frequently support students who experienced sexual violence and were also involved in Greek life in some capacity. Because of the event, they frequently lost social support from either friends or acquaintances. So in an effort to not choose sides, or friends would in fact choose sides, survivors would lose those friendships and those spaces of support. So that just furthered their isolation on campus. Perfect. So let's cover what this looks like in the US. So the lifetime prevalence of PTSD in the US is just under 8%. The lifetime prevalence of PTSD for sexual assault survivors is around 31%. In the 2 weeks following a sexual assault, 94% of women experience trauma symptoms. I use this point to discuss the fact that this is within 2 weeks. So some people may not experience symptoms immediately or within those 72 hours, or even 1 to 2 weeks after. We can't always expect to see these symptoms immediately or in the couple weeks after a sexual assault, and that is totally normal. I also think it's important to note that this particular statistic focuses on women. We are paying attention to the research around men, but it's less available. So sexual assaults is the event most likely to cause PTSD, and women are more than twice as likely to experience PTSD than men. So transitioning a little bit to false reporting. What do we think about false reporting, and how does this show up in our own work? In 1996, Eugene Cannon published a study finding that 41% of rape accusations in a police agency were false, filed to provide an alibi, seeking revenge, or obtaining sympathy and attention. Victims were told that they had to take a polygraph, and if their account was not able to be proven, they would have then been charged with a false report. New evidence-based research shows that the true rate of false reports for sexual assault is somewhere between 3 and 8%, which is around the same number for other types of crime. When someone is sexually assaulted, they may behave in ways that some people find difficult to understand. Though these behaviors often lead to victims not being believed, their behaviors, in fact, are normal and neurobiological responses to their experience. There are many different regions of the brain that are impacted by trauma. We're just going to cover quickly what that might look like. So Laura, when you're ready, if you could pop to the next slide, and we'll just quickly watch this video that covers what's going on in your brain on a high level.
We need to take a statement so we can establish what happened on Saturday night.
What time did you get back to David's flat?
What time? I don't know.
Can you give us an estimate?
I don't remember.
Would your pals remember what time you left the club?
He seemed nice.
She didn't remember much, did she?
I know. And now we've got to waste more time on a daft lecture. We know how to deal with victims. We've had years of experience.
Well, some of us have had more years than others.
I'm in my prime, I'll have you know.
That'll be right.
Today's session is about trauma. The latest in brain science will help you in your work. I'll start with a tour of the parts of the human brain. The reptilian brain maintains basic bodily functions. The limbic system is also instinctive. It deals with fear and pleasure. For example, you pat a dog, it senses pleasure, and without thinking, wags its tail. The neocortex is the site of logic, imagination, planning, and control. It's more sophisticated, but because it's conscious, it's slower than the older parts of the brain. The amygdala is a key part of the limbic system. It has one job: to sense danger and set off the alarm. When it's a matter of survival, the primitive parts of the brain override the conscious part. There are three possible survival responses: fight, flight, or the one that people don't think of, freeze. When the alarm goes off, blood and oxygen are diverted to muscles, adrenaline floods the body, and all systems that are not crucial to survival are switched off. Normally, the job of the hippocampus is to file memories so you can retrieve them later. But in times of danger, it stops filing memories, which makes it harder to gather evidence later on. Instead, the hippocampus switches to pumping cortisol. What's useful about cortisol is it stops us feeling pain, so we can focus on survival. Can anyone give me an example?
A farming accident where a man carried his own arm for a mile without feeling any pain?
Yes, excellent example. It is an evolutionary safety mechanism, which is fast and instinctive. In essence, it's our body's very clever way of protecting us. To recap, an example of the three parts of the brain working together. You're standing at a bar. Your reptilian brain is keeping your heart beating. You're enjoying the pleasure of a nice pint with your limbic system. You're using your neocortex to work out if there's time for another before the last train. What could happen to make the amygdala kick in? What if this happened? The way you'd respond would depend not on your logical brain, but on your instinctive brain. Being glassed in a bar would be a traumatic experience. Who can give me another example of an event that can cause trauma?
War?
Rape?
A car crash?
Good, yes. Trauma occurs when a person is overwhelmed by something beyond their control. The survival brain takes over the rational brain. It can lead to post-traumatic stress disorder, PTSD, with symptoms that last at least a month. Vicarious or secondary trauma is something you may experience if you deal with incidents such as rape or sudden death, or think of Lockerbie, Dunblane. You're not superheroes. Having a brain makes you all vulnerable to secondary trauma. It's important to understand that when trauma occurs again and again, it can become complex PTSD, such as in domestic abuse or child sexual abuse. The alarm system in the brain becomes jammed. Memories are stuck in the limbic system, so a trigger can set off the alarm. The trigger could be anything: a colour, a smell, a sound, a sensation. Now, the indicators of trauma. What should you be looking out for?
Depression? Crying a lot?
Yes, that's one response. And at the other end of the spectrum, total numbness.
Nightmares? Flashbacks?
Stress?
Good, yes. And they may feel sick. Also, shame, feelings of guilt, inability to enjoy sex, social isolation, triggers. People often feel overwhelmed by the symptoms of trauma. This can lead to using alcohol or other drugs to block out memories, or self-harm, or dissociation when a person's mind detaches from reality. Indicators can be specific to the type of trauma. Say, dental problems, when someone who was orally abused avoids going to the dentist. A victim of abuse might bond strongly to her abuser. This is known as traumatic bonding, or Stockholm syndrome. And jumbled up memory, when a person's normal recording of memories doesn't work. Can you recall any times you've seen that symptom?
What time? I don't know.
A traumatized person may not seem like her usual self, or may be hypervigilant, on edge, or being startled by everyday things. Everyone is different. You never know what impact trauma will have. Symptoms can change from day to day. So what does all this mean in practice, in your job? A traumatized person's brain is protecting them, but that normal human response of self-protection can get in the way of evidence gathering. The US military has developed new trauma-informed interviewing techniques that you can use to work around this. Research shows that if someone seems vacant, they could be distracted by their traumatic memories. Try to ground them by asking a simple, non-patronizing question such as, "Are you thirsty? Do you want a glass of water?" This can help bring them back to the here and now. Don't expect a logical, linear story. Ask, "What can you recall just now?" Find out what the victim physically felt or saw. Working this way, from the instinctive sensory parts towards the logical parts of the brain, you'll get more results. In conclusion, 4 things for you to take away. Trauma response is the brain in survival mode. Repeated abuse can make trauma symptoms worse. In response to trauma, people will behave in unexpected ways. Remember, trauma is a normal human response to abnormal events.
We know that you've gone through a really painful experience, but we need to take a statement to understand what happened on Saturday night.
Are you able to tell us anything that you remember about his flat? Anything at all?
A dog barking.
Are you able to remember any physical sensations or feelings that you had?
Cigarette smoke. I can smell it now.
What was going through your mind?
I couldn't understand it. I just couldn't move or even scream.
To freeze is a perfectly normal response. So you start with the memories, you don't start at the beginning. You have to engage with feelings to get to the facts.
Makes sense. Check you, Professor, getting all sciencey on us.
Well, if it gets us usable evidence.
There's life in the old dog yet.
Oi.
So better being able to understand the neurobiology of trauma and what's going on for a survivor, I think is an important way to potentially avoid secondary victimization. So as service providers, we of course want to avoid secondary victimization. And for those that don't know, secondary victimization is defined as the victim blaming attitudes, behaviors, or even practices that community service providers, law enforcement, college administrators can engage in that results in additional trauma for sexual assault survivors. So to quote a sexual assault survivor, "As if the rape was not bad enough, I had to go through everything that I did with the police and the doctors. It's just more rape. The rape keeps going on and on, like you can't escape." So the most common example, I think, is when law enforcement discourages victims from making reports in the first place. Law enforcement might tell the victim that what they experienced was not serious enough to pursue a case in the criminal justice system. So 70% of the time, law enforcement asked victims about things like what they're wearing or even the behavior prior to the event, which obviously can insinuate or imply that the victim may have done something in order to provoke the event or the assault itself. And while those questions may in fact be relevant to an investigation, the ways in which they are presented can be deeply harmful. So when we think about our own work with college survivors, how can we minimize that secondary victimization? It's important, while we are not law enforcement, we can do harm and we can continue to victimize survivors. So how do we avoid that? And what does that mean in a really tangible and practical way? For me, I think about trauma-informed care as one of the most powerful ways to avoid further victimizing and further harming survivors. Laura, if you wouldn't mind going to the next slide. Perfect, we're good where we are. So, what do I think the value in trauma-informed services is? First, I think it's important to know that trauma-informed services can help serve to continue engagement for college survivors. So when we practice trauma-informed care, survivors are more likely to participate and continue to engage with you and get the support that they may want or need. Additionally, it's mutually beneficial. So when we think about this, we're not only helping survivors, but we're also helping ourselves. We're better able to do our job. So a trauma-informed approach is one that recognizes that the behaviors and responses survivors display are directly related to their experience. And this experience can cause mental health issues, substance abuse, and physical health concerns. So trauma-informed care is based on 6 key values. First, safety, trustworthiness and transparency, peer support, empowerment, voice and choice, collaboration, and then lastly, cultural, historical, and gender issues. So how do we put this into practice? How do we live out these values in a tangible way? I am going to run through a few quick examples of each of these values in my own work as with students, but please know that these examples are not at all exhaustive, nor would they be appropriate for every case, but really just getting you to think about how we can apply these in our own work. So first, I think about safety. Are students safe on campus? For many students, safety means different things, right? So are they safe in their body? And that's really where Dr. Volz is going to start to come in with her medical care. But I think especially about, am I making the physical space where I work safe? So, for example, I previously worked in Title IX and in student advocacy. My office was in the middle of campus, and it was the only space that Title IX operated in. So if you were coming into my building, everyone knew that you were coming into the Title IX office. There wasn't another service provided in the physical space. So for a lot of survivors, that was not comfortable or safe because it outed them as a survivor or somebody working with our office. And then additionally, if they were in a domestic violence or stalking situation, it potentially created a safety risk. So how do we think about making our spaces more safe? For me, you can think about a virtual option if that is something that your institution allows. We can also think about booking spaces that meet students where they are. So a lot of my students preferred to meet me at another location on campus. So can you book out a room and maybe in the library or other shared spaces that are a little bit less obvious? And then if students do feel comfortable coming to you in person, this sounds really basic, but is your space, meaning your office, somewhere that you would want to go for help? Do you have a large, intimidating desk? Is it a welcoming space? There's simple things that you can do to make coming to your office for support a little bit less intimidating. So for me, I always offered students a drink, whatever that was, something to hold, whether that's a fidget, the drink itself, voice and choice in where they sit in your office. Can you make the space slightly more comfortable for them? So moving on to the next value, trustworthiness and transparency. I think a lot about this with our younger students, especially around reporting requirements. So if you are a mandated reporter, can you explain that to students in a way that they understand? So are you a mandated reporter for Title IX violations on your campus? What does that mean when somebody comes to you for support? Are you transparent in telling them that before they disclose? If they do share with you, can you answer questions around next steps? Can you share where their information is going to be documented and who has access to that information? It's always so upsetting to me and to students when they would receive outreach from Title IX, thinking that they were going to a confidential resource on campus, and then realizing that resource was not confidential, and then being upset when they received outreach. So how can we avoid that? Additionally, many students come to campus as freshmen at 17 years old. So if your licensing requirements dictate that you have to make a mandated report, are you transparent in that when they share? And how can you explain that in a way that they'll understand? Additionally, many students, a barrier to reporting or receiving help is their concern around drug and alcohol use, or drug and alcohol use at the time of the incident. Can you succinctly and accurately describe any sort of institutional policy around drug and alcohol use? And then finally, I think for transparency, a big one that comes up with college survivors, and I'm sure Jess will be able to speak to this, is will my parents find out what happened to me? So for me, I think a big one is being able to explain what a safe is to them, being able to help them through the compensation process. So if they're getting support through campus health resources and they're on their parents' insurance, how do we work around any sort of concern about their parents knowing? And then if they're engaging in some sort of Title IX process, are we explaining what FERPA is to them? Are we explaining that they're entitled to an advisor? Are we giving them multiple modalities for that information? So it's one thing to say it in a meeting with a student, it's another to provide that resource in writing. What we know about trauma is that many people need multiple modalities because of those executive function issues. So are we providing that? So I think peer support for me is one of the most important spaces to be able to provide trauma-informed care. So while many students do want support from campus service providers, frequently peer support is a really powerful and, for me, inspiring space for healing. So I always tell my students that peer support looks different than what I can provide. So support coming from your friends and your peers means something different from somebody who hasn't been in college in 5 to 10 years. I don't know what their day-to-day life is, where their peers can relate to them in powerful ways. So for me, I always tried to offer, if there are peer support groups, so that can look like a lot of things on campuses, but recovery groups, affinity housing, some places have survivor support groups, or even peer educators. So do you know those resources on campus? And can you provide that to your students in a way that meets them where they are? I think a really great one for our student survivors, especially those who might be struggling academically, is peer support around academics. So most campuses have some sort of tutoring or on-campus help around academic work. Typically, they're taught by peers or graduate students. And this is a great space to fill in some gaps, especially around supportive measures for academics. So can we connect them with those folks? And those tutors have a better idea of what it is like to be in college today. so they can help plan around specific syllabus related issues, and then also like lifestyle. So our survivors still have all of these other things outside of their trauma experience that they want to engage in college. And peer support is really a space where we can start to fill those gaps. So fourth, we're thinking about empowerment and choice. As service providers, I think we have to understand that there's an existing power dynamic between our students and the survivors and we as service providers. So how do we flip that power dynamic? How do we empower students to make choices that are right for them? And how do we give back that choice and that power and control? They've already gotten through something where power and control has been taken from them. So how do we flip that script a little bit? For me, I think a lot about the supportive measures that Title IX can provide for students and giving them voice and choice in choosing what supportive measures are best for them. So maybe that is just academic support. Maybe that is handoff to other resources. But one, meeting students where they are, two, listening to what they need, and then giving them the option in how to receive that support. So tangibly, maybe that looks like you give them the information for on-campus mental health support, or you connect them with that clinical supervisor directly, but giving them the option of how they want to opt into services is empowering. So thinking about collaboration, how do we level off those power differences? Where can we include them in this process, in their own healing process? So how can we include them maybe in some of that on-campus work? And then lastly, cultural, historical, and gender issues. I think this really applies when we're making referrals, either on or off campus. So one, are we being intentional in those referrals? Are we meeting our students where they are and what they need? And then thinking about making appropriate referrals. So if a student has not asked for a referral, is there a reason you're giving it? And can you explain that reason? Can we give affinity or identity specific referrals if that's helpful? So Laura, when you're ready, the next slide would be great. So quickly, just to wrap it up, there's some general principles for all service providers. We want to understand that there's no such thing as a typical perfect survivor. They're not a monolith, and their behaviors and experiences are all unique. So it's really important that we work to meet students where they are in their healing. And they can express that in a range of behaviors and emotions. There's no way to prepare for sexual assault. It can be difficult to know what the best choices are, and the way our body responds to trauma can look really different. So thinking about how we can support them through that. So moving on to do nots when you're ready. So it's important to remember a lot of that biology that was covered in the video and that information around trauma and PTSD. So again, there's no perfect survivor, no typical victim. We want to avoid asking questions that unintentionally might verge into victim blaming. So we don't want to ask questions like, why didn't you act more rationally? Or why didn't you fight back? Why didn't you run? We can't expect survivors to be able to narrate what happened to them in a chronological manner. So survivors may recall details differently after they sleep. So we really want to think about where we're catching survivors in this process. And then It's perfectly normal not to remember the assaults. And we might remember specific details of the assault, but we might not remember that in a chronological manner. So I'm going to transition over to Jess quickly, but as providers who work on campus, regardless of your the space you hold on campus, we want to be able to facilitate those handoffs for safes. And when we think about safes, and safety specifically is an important part of trauma-informed care, we want to move beyond, do you feel safe on campus, to a greater and more dynamic sense of safety. So do you feel safe in your body? And do you need medical care? And then as campus providers, can we accurately, succinctly explain what a safe is and hand them off to people who can better support them? When we think about our excellent FNEs and the care that they provide, they have different reporting requirements than college campus professionals do. And they might be better suited or what that survivor needs more than what we can provide. So when we think about that voice and choice, safes are an important spot to make referrals that better meet survivors where they are. I'm going to pop it over to Dr. Volz now to cover safes.
All right. Well, thank you so much, Grace. So I am today going to review very briefly what a forensic nurse examiner is, what a sexual assault nurse examiner is, a little bit of the difference between specifically how we do the exam, and kind of what people can expect when they come to us in the healthcare setting after a sexual assault. Forensic nurse examiners, you may have heard that term, and sexual assault nurse examiners, they're a little bit different depending on the area that you live in and where you're seeking treatment. In the state of Maryland, we have licensed forensic nurse examiners. That's somewhat unique in the nation, that it actually goes through the Board of Nursing, that forensic nursing license. If you look nationally, there are sexual assault nurse examiners. The forensic nurse examiner can practice forensic nursing outside of sexual assault. Sexual assault nurse examiners are very specific. That is through our professional body. It's a certification by exam, and that's through the International Association of Forensic Nursing. So in regard to responding to sexual assault in the medical setting, they are both the same. But just if you hear those two terms, those are kind of the differences between the two in the background. So forensic nurse examiners are specially trained advanced practice, for example, nurse practitioners or registered nurses that have completed additional training. That additional training typically looks like a 40-hour didactic course for adults and adolescents, and then an additional 40-hour course for pediatrics. We are trained in providing trauma-informed, patient-centered, objective care. And this is really important that you know when you are referring someone, or that you are encouraging someone to go to perhaps to the hospital for a medical forensic exam, a sexual assault exam, that you should send them with the expectation that the medical provider is a trauma-informed person and will treat that person respectfully and communicate with them in that way. We are professionals with specialized knowledge in medical care, treatment, and evidence collection for people who have experienced sexual assault. The evidence collection piece is typically the first part that people think about. They think going to the hospital for a quote unquote rape kit. And though evidence collection, whether that be DNA evidence collection or debris or clothing, all of those things are within our scope of practice. What I like to encourage everyone to do is to reframe and focus first on the medical care and treatment. People who have experienced sexual assault have potentially been exposed to sexually transmitted infections, including HIV, infections such as gonorrhea and chlamydia. Oftentimes, there's a concern for pregnancy. And this isn't just in the context of sexual assault that's perhaps by a stranger or an acquaintance. If you add the element of intimate partner violence, so maybe on campus, this is a boyfriend-girlfriend situation. If you add that element, actually, the chances of the risk of sexually transmitted infection is actually even higher. So if this is someone who says, well, you know, I'm not sure that I really want to go and receive medical care. I don't think that I need medical care because, you know, I have had previous sexual relations with this person. Because of that dynamic in the relationship, that actually puts them at higher risk for sexually transmitted infections. So I would still encourage those people, you know, who report that as, you know, kind of a reason they don't need to seek medical care, to go and seek that medical care anyway. We also look at patients, sexual assault nurse examiners are nurses first, right? And our patients are patients first. And what we really like to do is make sure that we, again, are approaching the medical care first and approaching people in not just a trauma-informed way, but a holistic way, making sure that they have the wraparound services that they need, making sure that they are engaged with an advocate, and making sure that they are really informed about the medical decisions that they are allowed to make. So again, what we are not evidence collectors alone. And this is important too. We're not able to definitively determine if someone was sexually assaulted. That determination is made in the courtroom. Our job, as far as interpreting any type of medical exam, treatment, any injuries that we might see, that's really a pretty complex thing to do. And ultimately, we can either say one of two things. This is consistent with someone's report of sexual assault, you know, that they reported to me, or it is inconsistent. And really, to be inconsistent, there has to be some really pretty strong, I would say, you have to basically rule out and say it's medically impossible. So it's really difficult to do that. So just so that you know where our opinions are formed and kind of come from. We are not professionals who diagnose rape or opine on consent. That again is something that is done in the courtroom. Rape is not a diagnosis, and we can't give an opinion on consent. In the absence or presence of injury, it's well known in the forensic nursing and medical literature that absence of injury does not mean that someone was not sexually assaulted. So that consent piece is really something for the legal system. And we're not victim advocates or investigators. So we provide a clinical role, and we can help you interpret those medical findings, but we're not investigators. And we're also not victim advocates. And I'd like to make this distinction. We are patient advocates because we are nurses, we're nurse practitioners, we're medical providers, right? So we advocate for our patients, whether they are coming, regardless of the complaint. We're going to advocate for their their care and their well-being. Victim advocates are a little bit different in their role. And I think, Grace did a great job describing that. I think we're ready for the next slide. Thank you. Services provided by FNEs or SANEs. As I said, we do provide screening and prophylaxis for sexually transmitted infections and HIV. So there are medications that can be given for prevention of HIV if someone was exposed to the HIV virus. These medications are a 28-day regimen, and there are 2 medications. I see that we have some people from out of the state of Maryland. It really varies by jurisdiction, what access people will have to that medication, and by state. Here in Maryland, the great thing is we have the ability to provide that medication completely free of charge to the patient. We also have the ability to provide prophylaxis for sexually transmitted infections. So right off the bat, if someone reports a sexual assault, they should have the opportunity to prophylactically take antibiotics for infections such as gonorrhea and chlamydia. We offer free pregnancy prevention or emergency contraception. So within the first 5 days of a sexual assault, we can provide 2 different types of medications that can prevent pregnancy. We also provide admission and planning for survivors of non-fatal strangulation. And the reason that I specifically point this out is because we have found that non-fatal strangulation occurs frequently, especially in cases where there's an intimate partner violence component. It's less likely, but still prevalent among people who have suffered sexual assault. But we found in our program alone that around 60% of people who are presenting with an intimate partner related assault, whether that be involved sexual assault or not, report that they were strangled as part of this visit. We didn't even look retrospectively had they ever been strangled by their partner. Strangulation is a very dangerous act. And so I like to make sure that everyone who's responding to someone who's been sexually assaulted knows that they should ask this question if they have been strangled, because it's not something that people typically will disclose on their own. And that if they do disclose that, certainly you should refer them to a medical provider. Consultations, we in our program provide consultations. And the reason I say this is if you don't have a program in your area where someone can call a forensic nurse examiner and talk to them about their medical options, their concerns about their body, we are here. So we have staffing all the time. Our nurses are not on call, they're in-house. And I always like to make sure that people know, regardless of where a patient is or a person that you're working with is, you can always give our unit a call. We offer follow-up exams for repeat sexually transmitted infection testing and pregnancy testing as well. We also provide disposition planning and case management. So making sure that we're having multiple touches with patients. Again, this is not a resource that's available in every jurisdiction, and I definitely acknowledge that. But the reason I mention it is if you have someone that maybe was sexually assaulted that you're working with, and they say this was a month ago, you can feel free to give us a call and we can at least point you in the right direction. Or if they're going to see their primary care physician, maybe that person doesn't know what tests to order. We can certainly help with that process. Okay, forensic nurse examiners are also skilled in screening for service eligibility. Again, evidence collection, injury documentation, and interpretation. And I should underline interpretation, because a lot of places a lot of medical settings can document injuries. They might not do it in the same way. They might not measure every injury. They might not take photographs of the injuries, but they can document those injuries. But really, it's that interpretation piece that's important, and forensic nurse examiners can certainly support you in interpreting any findings, or, as I said before, lack of findings. Safety planning, medical screening and treatment, resource identifications. Forensic nurse examiners are typically pretty savvy about knowing what resources are available for their patients, so they're a great resource in that way. We provide expert testimony in the courtroom, so helping juries and judges understand the medical documentation and what that means, understand the exam process, and we participate in multidisciplinary teams. For example, in our community, I'm the co-chair of our sexual assault response team, and FNEs are typically very involved in the community and serving that way. So they're a great resource that way as well. The purpose of the medical forensic examination is physical evidence recovery, injury identification, and documentation. And as I said, we do that a little bit differently in that we measure injury, we photo document injury, we have special ways to protect those photographs, and understand, the principles of forensic photography. Address the special medical needs of victims of abuse, assault, and neglect. And those medical needs really in the nursing model extend beyond physical needs, and they, help ensure that the patient's psychosocial needs are also acknowledged and met, and aid in the healing process. So what can people expect? They can expect that this is not a test. We don't test for, I have heard it all. We don't test for virginity. We don't test for sexual assault. It's not a test. It really is a medical process to make sure that the person is cared for. But again, shifting the focus that the primary purpose is not evidence collection. That is a piece of what we do. It is definitely not the largest piece of the puzzle. The exam, we will collect. So sometimes people say, well, what are they going to ask me? It's reasonable to expect that a past medical history will be collected. This guides the exam, it guides the care, it guides the medications that we might give, a physical examination, and photographs and physical evidence collection. I want to pause here for just a second and say, not only with the exam, but also with the medications, with the medical recommendations, anything that a patient comes to the hospital for that's related to a sexual assault exam, they have the opportunity to participate in or decline. And so this is important for patients to know that they should feel absolutely no pressure to participate in any particular part of this exam, but they should have these options available to them. That medications will be available to them, again, around sexually transmitted infection prevention, HIV prevention, and pregnancy prophylaxis. They can expect that medical recommendations will be made for them, both for their physical needs, as well as any mental health needs or psychosocial needs, and safety planning. So we always make sure that our patients are leaving the hospital with a safety plan. And even if that involves, making sure that they get into shelter temporarily or have access to a protective order, we should be making sure that that process is at least in place for them and that they can participate in that if they want to. There are 3 different reporting options when people come to the hospital. Different communities call these different things. Some places call it anonymous reporting. Some places call it Jane or John Doe exams. For our purpose today, I'm just going to refer to it as anonymous reporting. So we're going to go through anonymous reporting, sexual assault evidence kit collection, and consultations. So when someone comes to the hospital, they have 3 options, as I said, available to them. One is medical treatment only. So that means there should be an expectation that they can present to really any emergency department. This doesn't even have to be a place with a safe program or a forensic medical unit. And they should be able to receive STI prophylaxis, HIV prophylaxis, and pregnancy prevention. They should also be able, they should have the expectation that when they go in, any injuries that they have will be addressed. Sometimes, people are experiencing a trauma reaction and they need additional support from, the therapy team. All of those things are included in the medical care. With the medical care, they should also be provided with the option of engaging with an advocate if they want to. Option 2 is that anonymous reporting. And my program, and hopefully other programs are doing the same, intentionally presents the options in this way, from medical only to the anonymous reporting to standard reporting, because we want to make sure that patients know that we start with the least kind of invasive or the least potentially threatening way to participate in their medical care. And that really is, again, focusing on that medical care. The anonymous reporting says they want all of that medical care, but they also want a medical forensic exam with the evidence collection and photographs and all of those, wraparound services, but they don't want to report to police at this time. That's really important to know, because some people, how we describe it is that there are certain elements of their care that are time sensitive. These 2 options, the medical only and the anonymous reporting, those 2 options really take that those time sensitive interventions and allow the person to participate in them and save the thing that's not as time sensitive, which is the legal investigation, the law enforcement investigation, and take a breath and get to a place where they feel comfortable, if they ever feel comfortable, participating in that process. Here in Montgomery County, those kits are saved for 50 years. And by Maryland statute, they're saved for 20 years. So that's something that we definitely counsel our patients on. And nationally, I have seen this vary wildly. I have seen it from as little as 3 or 6 months before those kits are destroyed. All the way through here in Montgomery County, we say 50 years, but the practice is actually that those kits are stored indefinitely. And then finally, the reporting option of standard report includes the medical care, the medical forensic exam, and this is a patient who says, yes, I want to participate in a law enforcement investigation. And then we will connect them, if they haven't already been connected with local law enforcement or the law enforcement in the jurisdiction in which they were assaulted. It includes, again, evidence collection and photographs. We do consultations. We do consultations by phone. We do consultations with our local family justice center. If someone wants a face-to-face consultation, we'll do that via Teams, so we can virtually connect. We do consultations in the emergency department. We try to be as accessible for people as we possibly can in the way that they're most comfortable accessing us, if for nothing else, just to gather information and make an informed decision about how to move forward. And I always like to make sure everyone knows that sexual assault services that are provided in a medical setting within the first 15 days in the state of Maryland are covered by the sexual assault reimbursement unit, and those are done at no cost to the patient, including the 28 days of HIV prophylaxis. And I think we're ready for questions.
So while we wait to see if we have any questions, I'm going to go to the next slides, which include some contact information. Grace, this is my contact information, Laura Jessic, also with MCASA, but Grace, if you could put your email in the chat, I think that'd be helpful since you were the one actually presenting today. We just forgot to update this slide. And this is Dr. Volz's contact information as well. I know she's very receptive and willing to chat with people if they have any questions about what she presented today or what's available in Montgomery County. And she can also speak to what in some contexts what's available throughout the state. So with that, I'm gonna stop sharing my screen. And if we want to see if anyone's put any questions in the chat, you can also feel free to unmute yourself if you do have any questions. Steph, I don't know if you want to add anything.
Yeah, just that I am dropping the evaluation in the chat. So please help us fill that out. Help us by filling that out. I also know there were lots of people asking in the chat about what would be available after this is over. So we'll have the recording, other materials, including the YouTube link to the video, all coming to you via email early next week. So yes, you can look for that, and you can, I will put our info count in the email for info count in here as well. So you can also email us if you have any trouble. With that, does anyone have any questions? We've given you some time to think about it. I can unmute you, or you can drop them in the chat or the Q&A. Okay, friends, we will hang out for a couple more minutes, but with that, have a great rest of your afternoon. Thank you for joining us today. I do want to mention we will have our third virtual campus training at the end of November. So check your email, look for that registration. It is coming soon. We have a couple more details to put into place. So we do have a question about certificates and CEUs. Yes, that's part of the evaluation. If you fill that out, we will send you a certificate. So that that link I put in the chat, you just need to fill that out. We'll also include that link in the follow-up email. So if you miss it today, we'll include that in the email that's coming out early next week. Okay, friends, thank you so much. Have a great rest. Oh, did someone have a question?
I was going to say, I see 3 hands raised. I don't know if those are questions.
Well, let's find out.
So looks like a Patricia.
So Patricia, I'm going to unmute you first. So I'm unmuted you if you have a question for us.
If it's me, I don't have a question anymore. Thank you.
Okay. Well, then we'll move to Susan. So Susan, I'm going to unmute you. It looks like I can't unmute you, Susan, but feel free to unmute yourself if you have a question or drop it in the chat for us.
I don't have a question. I think I hit the hand by mistake. I'm sorry.
That's okay. That's okay. Desiree, also, you have your hand up, so I will unmute you.
Thank you so much. I do have a question. So what would you recommend for the doctor and the panel? What would you recommend for just a lay person to instruct someone that shares with us about a recent sexual assault? Like, obviously, we will call 911 or assist the victim to go to the hospital. But I've heard a lot of things like don't take a shower, don't drink water, don't drink anything, don't eat anything, don't change your clothes. I'm not sure if that was something I heard from my training or I've gathered this information from the TV.
No, that's a great question. So, and I'm trying to give you the least restrictive advice. What I would say is, unless there is an urgent medical concern, they don't have to go by ambulance. So, for example, within the first 24 hours, I would say those general rules apply. Don't eat or drink if you haven't already. Because, for example, we collect from the mouth for 24 hours. So if it's been 3 days, then that person can eat and drink. And unless there's something pressing medically, they don't need to go by 911. I think that helps with discreetness to go to the emergency department. But what I can do is, in the interest of time, I can send out, I have for caregivers and community partners, a little pocket card that kind of tells you, what to do, what to wash, what not to wash, when to eat and drink, and when it's not okay to eat and drink. But ultimately, what I say is always think medical care first. So if this is someone who is really distraught and is saying, I'm so thirsty, I just need a sip of water, I just need a sip of water, that's going to come before the evidence collection. But I can send out some general tips to the group here.
Thank you so much.
Friends, any other questions before we close up? Yes, for those of you that are asking about kind of this wrap up, we will send the evaluation via email. Let me see here too. I can also, I know the chat's moving kind of quickly, so I posted it in the chat one more time. If you fill out that email, that evaluation at the end, there will be another link to where you can get your CEUs. So you can fill that out today or when it comes up in the email. And in the follow-up email early next week, we'll send the recordings, other materials, the video, and we'll send the information that Dr. Volz just talked about with that card. We'll send all of that to you early next week. You can also email info@MCASA.org with any follow-up questions. Okay, friends, thank you so much for joining us. And we will hopefully see you at the end of November for our next virtual campus training. And enjoy the rest of your day and have a safe and fun weekend.